Webinars have become the accepted way to safely disseminate information. I hope that you will enjoy this webinar and find it informative and interesting. I would now like to introduce this evening's speaker. Professor Wan Fai has links to both organisations as a trustee of the BSSA and as a member of the Medical Board of Sjögren Europe. For his day job, Fai is the Professor of Rheumatology at Newcastle University, an honorary consultant rheumatologist at Newcastle Hospital's NHS Foundation Trust, the Deputy Director of the National Institute for Health Research Newcastle Clinical Research Facility, and the academic lead for the NIHR Bioresource Centre in primary Sjögren syndrome. So in addition to his clinical roles treating patients, Fai is a very active researcher, both nationally and internationally. Before we start, I would like to thank my colleagues on the board of Sjögren Europe and the trustees and manager of the British Sjögren Syndrome Association for supporting this event. A special thank you goes to the Sjögren Europe treasurer, Catty, who with her team is in charge of the technical organisation. They are the wizards behind the scene who make the magic happen today. This webinar was organised with the help of unrestricted grants from Norgine, Novartis and Servier. Thanks to them for their trust and support. Sjögren Europe, the BSSA and the content of this webinar are totally independent from these companies. Sjögren Europe and the BSSA strictly follow the relevant codes of conduct between the pharma industry and patient organisations. After the presentation, there will be a question and answer session. If you have a question, please write it in the dedicated question box. The chat box is for comments only. As this webinar is for the benefit of Sjögren's patients and their carers, to ensure that questions posed by patients and carers can be answered first, both organisations request that industry colleagues refrain from asking questions during the question and answer session. Thank you, Fai. Over to you.
Thank you, Linda. I just want to check that everybody can see my screen. Is that correct? Yeah?
Yeah.
Okay, I'm going to make this into a bigger one. So first of all, I just want to say thank you for both BSSA and Sjögren Europe for inviting me to share some thought about fatigue in Sjögren with you. This is really, I actually see this as a big privilege to be able to interact with the people on the webinar today, and I can see that over 100 people signing up. I hope that what I'm going to share will be of some interest to you. So I just wanting to, I know that for most of you probably know that already. So fatigue in Sjögren really is a burden, not just to the patient, but also to the society. But what I'm also wanting to highlight is that actually, you may or may not know, it is also a challenge for our clinician and our scientists. So that is on that particular premises that I'm going to present my presentation to you today. Now, so first of all, I think, again, I'm sure that our people with Sjögren will know this. Fatigue is really common among patients with Sjögren syndrome. It affects about 70% of the patients with Sjögren, and over 40% of the people from Sjögren have rated fatigue being the most important symptom leading improvement. In fact, it is the top symptom rated by patient being the most important symptoms, closely followed by dryness. This is based on the data that we collect in the UK primary Sjögren syndrome patient of over 843 patients. Now, but it is also interesting to comment, because I'll come on to that later. Some people with Sjögren syndrome do not appear to experience significant fatigue, although they are definitely a minority. Now, but however, I think we also needed to recognize fatigue itself is not the unique features of Sjögren syndrome, because fatigue seems to be also common in a lot of different chronic diseases, such as rheumatoid arthritis, lupus, inflammatory bowel disease, Parkinson's disease, and Huntington disease, and perhaps actually many other chronic diseases. So that is important to bear that in mind as well, because it may shed some light into the underlying pathogenesis. Now, but I think, of course, we know that fatigue is a huge burden to patient and society. From the patient's perspective, as I already mentioned, it is often the most disabling symptom leading treatment. And also, I think in a lot of the condition, it's often the first symptom that they notice. When you look back when I see patients with Sjögren, and in fact in some other rheumatic diseases, if you look back, the first thing they notice is actually they get a lot more tired than they normally feel. But it's also quite interesting is that at least in the context of inflammatory-mediated inflammatory diseases, fatigue often persists even when we think that the underlying condition has been adequately treated. I think that is particularly prominent in situation like rheumatoid arthritis, because we often see patients, as far as we are concerned, their joints are no longer inflamed, and it's just that they continue to feel really, really tired. And I think patients also therefore quite rightly feel that actually fatigue should be included in all the core outcome measure, because there's no point just treating my joint, for example, if they still really, really tired, they still can't run their daily life or go back to work. I mean, that can clearly is understandable. And of course, for them, it's also significantly associated with impaired activity of daily living. They may often sometimes have to work less or even lost their job. And of course, the health-related quality of life is really, really poor. And because of that, I think a lot of the time people didn't realize that fatigue is in fact is an increased mortality for patients who got chronic fatigue. And that, of course, will be translated into increased society and healthcare costs through sick leave absences, job loss, disability claim, and also increased medical consultations. So when you see that, you will just be thinking, well, if that's the case, why are we not doing more about fatigue? Why do I still come to the clinic? And often, patients would complain that doctors are not listening to them about the fatigue or not treating the fatigue. So the reason is actually, I think there are four main reasons. So first of all, I think there is still some uncertainty about defining fatigue properly. And we certainly don't know what causes fatigue yet. And we also don't know how to measure it. So sometimes it's very difficult to know, are we really giving the right treatment? And of course, currently, we don't really have any treatment for fatigue. That's probably explained, not an excuse, probably why sometimes clinicians have been shying away to discuss fatigue when they see their patient, because they really don't know what to say about it in some way. Now, so you may find it strange when I say, what is fatigue? Everybody here probably have had some experience we call fatigue or tiredness. So how could we not know what is fatigue? Now, because I think often, when I see patient in the clinic, that is not necessarily the same fatigue that patient go to see their doctor for. The fatigue seems to be different from their usual, day-to-day experience of fatigue, especially compared to when they were healthy. So I think there are some what I would say is the key features is they are often more profound and often more prolonged. They're often unpredictable, and they usually persist even if they have what they thought is adequate rest. But there may be other features as well, and I'll be interested to hear from our patients here, their own experience. So the other thing that often talk about is that dividing up the scientific community is that are there different type of fatigue? Are they physical fatigue? Are they mental fatigue? Are they central fatigue? Or are they peripheral fatigue? There's a lot of different terminology being thrown around. That can actually make research very difficult, because people often say, well, are we talking about the same phenomenon here? I think the other thing is that it's unclear, is that we are not too sure whether those different type of fatigue are truly different type or just the same phenomenon but different manifestation. And also what we are not too sure is that the fatigue that experienced by, let's say in Sjögren, are they the same as those experienced by rheumatoid arthritis or other chronic diseases? So there's quite a lot of uncertainty in terms of understanding fatigue. So what about fatigue in terms of from a researcher perspective? Now that problem remains. Actually, at the moment, there is no consensus definition. No single researcher have an agreed consensus definition of what is fatigue. So typically in the research study that is being reported or being used are usually basically defined by the fatigue measurement tools. In other words, the questionnaire that they use in a particular research study. But even worse, actually, even when the study using the same research questionnaire, different researchers use different cutoff values. There's no agreed cutoff value to say, okay, so this is fatigue and this is not fatigue, and this is also variable. So that makes really difficult to compare different research findings as well. Now, so I think as a starting point, this is how I see fatigue as a researcher and clinician. I believe that it is a multidimensional phenomenon that can affect our biophysiology, affect our cognition, affect our motivation, and also affect our emotional state. Now, I do believe fatigue is a state rather than a disease. So, i.e., so it's not one day you have a disease and next day you have not a disease, but actually a continuous state of the body. But at that particular stage will result in a significant impairment of the individual ability to perform the function in their normal capacity. So that's important. So therefore, individual experience can be very different. So it also means that you can't compare one person's fatigue level with the other easily, because their normal capacity may be different between individuals. Now, so let's start to think a little bit about what causes fatigue and how can we manage fatigue then. Now, so I think the most talked about phenomenon is this sickness behavior. I'm sure you all have been feeling sick, having a cold in a woman and a man flu, and you can see the reaction is often very different. But I don't want it to be gender specific in here. But in general, the sickness behavior refer to the constellation of non-specific symptom of sickness. So in other words, feeling weak, feeling tired, feeling achy, unable to concentrate, and somewhat feeling a bit down and lethargic. So this is what we collectively call it a sickness behavior. Now, the theory behind the sickness behavior, it is actually a highly organized strategy of the body to fight against infection. So one of the reasons that the proposer of the original scientists who suggested this sickness behavior is that, for example, we know that fever is a very effective strategy to deal with infection. So, but in order to raise 1 degree of body temperature, actually the body needs to increase by 13% of the overall metabolic rate. So there's a lot of energy we needed to spend in order to raise temperature. But also there is a motivational interpretation, because if you are feeling sick, you don't want to be in a competitive environment to fight against other individuals who are not sick in the Asian society where you might need to fight for your life. That may not be particularly appropriate. So hiding away, feeling, getting rest would be probably more appropriate, strategy than, living a, normal life. And of course, inflammation itself have a lot of indirect effect. So for example, it would disrupt the circadian rhythm. It would affect the sleep. It also increasing oxidative stress. It induces depression-like symptom, and also changes some of the neuroendocrine responses, in particularly the hypothalamus pituitary adrenal axis. Now, but however, I think although inflammation is clearly likely to play an important role in chronic inflammatory conditions such as Sjögren, but we do know that, as I mentioned, fatigue often persists in patients, even though they are apparent in clinical remission, when there's really no sign of systemic inflammation we can demonstrate. And also, we also come across patients who clearly have evidence of systemic inflammation without really reporting any significant fatigue. And also, fatigue often are quite highly variable, even within a day. So it would be very difficult to be explained by pure inflammation, because inflammation wouldn't change in this, such a dynamic level. So there must be other factor other than inflammation. They also contribute to fatigue. And also, we have recently shown, in fact, replicated and validated the finding is that although all patients with Sjögren would have a slightly increased inflammation marker in their blood, actually those people who got even higher level of inflammation marker in the blood often have less fatigue compared to those who have fewer, lower level of inflammation, even though they all raise compared to a healthy control. So suggesting inflammation itself, again, cannot be the only reason to causing fatigue. And in fact, when we put all this data together in a statistical model, we showed that the inflammatory cytokine, pain, and depression are by far the most important predictor of fatigue. So in a perfect model, we would see that everything will lie across the diagonal line here, but you can see by just using this 4-factor, actually you can predict the fatigue level reasonably well. Now, so our thought about the overall physiological model of fatigue is like this. So in any situation where you can cause inflammation, including in the case of Sjögren, inflammation itself can cause, of course, not just Sjögren syndrome, but a lot of different conditions. So in any kind of inflammation, you will cause symptoms such as fatigue, pain, and depression. But this is in the acute setting. So what happened when the inflammation persisted? Then I think something else can kick in, because when the inflammation becomes chronic, then the body is likely to develop some regulatory or other adaptive mechanism in order to readdress the balance, because you can't just hide away in a cave forever, because if inflammation is there, you still need to go out and find your food and do things. So the body will need to have some other adaptive mechanism to allow the body to continue to function. And those mechanisms can also contribute to fatigue, and also potentially also contribute to depression and pain. And what happened when people who have persistent fatigue is that some of those immune regulatory or adaptive mechanisms become dysfunction. So they got deregulated and continue to driving fatigue, even though when the inflammation itself has subsided. And of course, depression and pain also influence each other and competing a complex relationship in there. So what are those potential adaptive and other mechanisms that can develop in the context of chronic inflammation? Then many of those has been reported in the literature. So I'm not going to go through every single circle in this slide, but just to show that there are a number of different things that could be come into play. And as I said, inflammation can cause all changes in all these different system, and then all these systems can contribute to fatigue. And they also very likely interact with each other as well. And then, of course, these are not just unidirectional. All these factors can also have an impact on inflammation itself. But also, what I would say is that although inflammation could be a very important initiating factor in the case of Sjögren, as I mentioned to you, there are also other conditions where inflammatory mechanism may not be the primary cause of the disease. I think in those conditions, they may actually directly operate into some of those adaptive mechanisms I mentioned, and they can also contribute to fatigue. So therefore, in terms of, in fact, I would argue that any chronic stressor to the body could potentially initiate changes in these various systems that can contribute to fatigue. So therefore, I think one way to look at it in terms of the management of fatigue is to look at this as individual factor. And then when we're developing strategy, we should think about, how we can actually target each individual pathway to see whether we can, help with managing fatigue a bit better. Now, of course, we need to remember that there may still be something that we have not yet discovered yet. So one way we could look at it, so for example, using the question of inflammation, let's say if we think that inflammation were the key contributing of fatigue, then what we should be doing is actually trying to optimize the immune modulatory therapy to achieve clinical remission as much as we can possibly. And that's also why we sometimes, try patients with hydroxychloroquine or try steroid, but I would really have a caution about using steroid long-term, because we know that actually using it long-term, A, it doesn't work, and B, there is a really significant side effect, but it may have a role in treating acute fatigue, for example. And of course, if we're thinking about targeting pain, anxiety, and depression, we can think about there are different ways. You can use analgesia, we can use pain management program. There are some non-pharmacological means that we can also help managing pain. Similarly, for mood disorder, we can think about using antidepressant or other drugs, and we can think about, again, other non-pharmacological intervention. And then treatment of things that are, alongside the oxidative pathway, mitochondrial dysfunction, or cardiorespiratory fitness. We may think about, some exercise program. We can think about using potential supplement that may have some potential benefit. If you're thinking about the problem with circadian rhythm or sleep disorder, we may want to think about treating any underlying sleep condition, sleep education. There are CBT in insomnia. There may be other pharmacological intervention that may potentially play a role And physical activity and exercise training, again, can improve sleep. That may also help. And if you're thinking about the neurotransmitter metabolism pathway or other CNS, we maybe think about a lot of different other pharmacological intervention. And of course, don't forget our mind can be quite really powerful sometimes in modulating the neurotransmitter and our CNS network. And finally, in terms of autonomic dysfunction or the HPA axis, there may be potential drug or other non-pharmacological intervention that may be appropriate. In the case of the autonomic dysfunction, we can again think about certain drugs or thinking about medical devices such as vagus nerve stimulation. Now, so that's just a run through about the possible cause and how we manage fatigue. So what about how to measure fatigue? So where do we get up to? Now, so I already talk a little bit about the challenges in measuring fatigue. First of all, they are multidimensional, and then there are questions about whether we should measure the severity or measuring the impact. So in other words, whether we should measuring about how severe they are, or actually how much it affected the patient's daily activity. And how do we adequately capture the variability? And whether we should capture the momentary fatigue, or should we just capture the fatigue over a period of time and the average over a period of time? And how do we take into account of potential confounder, i.e. other effects such as the mood, pain on the reporting? And how do we balance between whether we should base on the subjective report, i.e. the report from the patient, or using an observed way, we actually observe how fatigued patients were, or whether they are perceived, either, in other words, whether they are, how much they can do, or actually observing how they do in their normal day-to-day function. I'll show you some example later on to explain this a bit clearer. Now, so for example, I'm just showing you some of the very common popular questionnaire that we use to measure fatigue. So for example, fatigue severity scale, which is very common, very simple questionnaire, only got 9 questions. But you can see really, apart from the very first question, they focus very little on the mental fatigue, that people often complain, like brain fog and stuff like that. There's no way this questionnaire would be able to capture them adequately. Also, in this questionnaire, they talk about during the past week, but we know that some of the questionnaire, they may ask about last 2 weeks or 4 weeks or, past 2 days or just recently. And of course, if you ask questions like this, it would be very difficult to capture any significant variability experienced by patient. When I use questionnaire in the clinic, I often have patient writing me a lot of explanation to say, yes, I am feeling it now, but actually, if you asked me yesterday, it would be very different score. And of course, if you're thinking about this, you're really thinking about, these are example about, whether this is an impact or severity, because in here, we're talking about fatigue interfering with their work, family, and social life. But also potential confounder in here, because we know that if we're just asking about this question, if somebody who don't have fatigue, just have depression, they will score relatively highly in this questionnaire. So therefore, understanding, the reason why people experiencing this is very important. And also, we wonder whether for question 2 and 3, whether there may be some better objective measure rather than just asking people to give a score, between 1 to 6. So I'll show you some example later. Now, so another commonly used scale is called Modified Fatigue Impact Scale. It's got 20 questions, but I'll just show you the first 10. So these are just some of the potential novel approaches we can measure fatigue using objective measure. So for example, if you ask the patient about how alert they are, we can actually use some neuropsychological tests to formally assess that. And in here, you can say, well, they have difficulty paying attention for a long period of time. Again, there are some neuropsychological tests that we can use to measure it more accurately and objectively. In here, they have to pace themselves in physical activity. We could actually probably, measure it using Fitbit, because we can actually see whether they actually pace their physical activity, by looking at the data they collected. And if in here, if they have trouble maintaining physical effort, we can actually measure their heart rate, respiratory rate, and we can actually see whether they can sustain that particular level of intensity of physical activity. So that may provide us with more sensitive, accurate, and reliable measure in measuring those particular features of fatigue. So indeed, some of these novel measures has been tested in some of these studies. However, often the sample size can be quite small, and most of the study often don't study necessarily using the right questionnaire, and some of these studies haven't really adequately controlled potential confounder. And I'm going to show you some example. So for example, in this study, looking at Sjögren, they were really interested in looking at whether some of the neuropsychological tests that I mentioned can really be a measurement of fatigue. Now, however, for some reason, clearly, I have absolutely no idea why this researcher using SF36 vitality component as a measure. You can see they only have 4 questions, none of them asking about mental fatigue. Why would you expect any correlation at all to any neuropsychological performance? Completely poor design study. However, if you think another group, they are cleverer, clearly, because when they look at these neuropsychological tests, they recognize that they needed to look at mental component. So they did also use fatigue severity scale because it's such a common scale that everybody used. They felt that they have to use it, or maybe some of the reviewers say that they have to use it and they have no choice. But they did include mental score. Surprise, surprise, they didn't find any correlation between neuropsychological performance and fatigue severity scale. I'll show you. There's no question asking about mental fatigue anyway. Why would you see any correlation? But when they do look at the Sjögren mental fatigue score, they were able to find quite a lot of significant correlation, showing that actually if you use the right outcome and right measure, you can identify some potential useful finding in this study. And in fact, we did a clinical trial with a company looking at a phase 2 clinical trial. We can demonstrate that this drug potentially really significantly improve fatigue. And we can also show that not only their mental fatigue score improve, we can show that their ability to perform a digital simple substitution test significantly improve. In other words, the group we've got active drug able to complete the test much quicker, whereas the patient in the placebo group, actually take them slightly longer, well, probably within the range of, variation. So this is really encouraging to show that some of these novel measures can be really useful. So there are also some other novel measures being tried. For example, I mentioned to you about using Fitbit, and we call them accelerometer, to measure physical activity. So we can also use it to look at cardiovascular fitness. So again, there has been a small study who published using that in Sjögren, but unfortunately, again, they just picked the wrong questionnaire to look at. So they didn't really find a lot of very crude measure, and they really didn't really analyze the data in much detail. But they did find a little bit of correlation between the time to get up and go time compared to the fatigue measure. But again, there are quite a lot of room for improvement in designing this study. I'm not going to show you that. But in fact, when we did a study that which is still ongoing, but we did the interim analysis. We actually measuring ECG and the physical activity, and we use a process called feature engineering followed by some computer modeling. In fact, we were able to now, using parameter extracted from ECG and physical activity, able to quite accurately predict fatigue level in patients. So that is leading to, and in fact, I also know that there are other similar studies using similar approach that has also been presented at a conference. So that actually led to our current study that I have the privilege to leading in terms of trying to identify digital endpoint to assess fatigue, sleep, and activity daily living, not just in Sjögren, but also extended into other conditions. So this study actually involving 46 organizations with a range of expertise, which is a 42 million euro project that we are focusing on looking at the 4 immune-mediated diseases, including rheumatoid arthritis, IBD, Sjögren, and lupus, and also neurodegenerative diseases, including Parkinson and Huntington disease. So the ambition is that we will be generating over 2,200 subjects with detailed digital and clinical data set, and hopefully we can use this to identify digital endpoint. So the overall approach is that we will be looking at 5 potentially digitalizable concepts of interest, and then we'll be using the appropriate digital device and technology to measure these 5 concepts of interest. And we are currently just completed our feasibility study, and we're going to take forward some of the promising digital biomarker to validate in a clinical study. So, so this is the overall study protocol. So in the first study visit, we have collected a lot of clinical and patient-reported outcome data. We asked the participant to wear these devices over 4-5 day period, and they are break down into 2 5-day periods, each had a different device combination to cover the 5 concepts of interest. So this is some of the example of how the device and being used. So some of them are fixed devices, some of them are variable, some of them on the mobile phone. We just have a right combination to make sure all 5 concepts of interest are being captured. So to summarize, so I would say that fatigue is a syndrome that often coexists with other symptoms, and there may be different type of fatigue, or just fatigue have different facets or different dimension. There are many questionnaires for fatigue exist, but we need to be really careful when we choose the right questionnaire for our own research and study. It is really important that we need to consider potential confounding factors that are critical in fatigue assessment. And I think it is important that when we look at fatigue, we needed to have repeat and longitudinal measurement, both in terms of clinic and also in research. And I think there are some huge potential for developing objective measurement of fatigue using non-invasive digital technology. And I think that would really complement the questionnaire-based assessment. In terms of the management, I think management of fatigue remained a challenge. And I think, but I think as a start, I think clinicians should acknowledge the symptom and understand the impact on the patient. I think is important first step, and I think patient would appreciate that. And I think a multidisciplinary and personal and also holistic approach, I think is the most likely required and most likely have the best outcome. And I think we first need to begin by assessing the potential contributing factors and then devise the appropriate targeted therapy accordingly. And it is important to treat any relevant comorbidity, for example, anemia, hypothyroidism, i.e. underactive thyroid. And I think at the moment, we would say that the effective treatment for this are still under research. So I'm just wanting to finish by acknowledging people in my group who contribute a lot to the research that I presented here today, but of course many collaborating partners and funders of a lot of our research. But most of all, actually, is the patient who has been so enthusiastically supported many of the research that I have run over the year. So thank you for your attention. And I hope by now you're still not totally zonked out and still being alert and listening. Thank you.
Thank you so much for your presentation. We know you, and we know how invested you are with all Sjögren patients. So thank you very much. We've got a couple of questions there. The first one will be linked to the pandemic. Do you think, Professor, that the research and treatments of those suffering from long COVID will benefit to Sjögren patients?
Yeah, I think there are certainly potential similarity. I guess, I think, of course, I mean, the verdict is still out, and there's still a lot of, unknown in fatigue research. My overall view, this is my personal view, I can't give you very concrete evidence to support that. I think the overall mechanism of fatigue are likely to be similar. I think my own reservation about long COVID is that at the moment, long COVID may well still be shorter than patient with Sjögren. So, some of the long COVID, I'm clearly not an expert in long COVID, but I do know that, for example, some of the patients with long COVID do recover after a few months. So the model may yet still be slightly different from Sjögren, because Sjögren often people have it for years, 10, 20, 30 years. And if my theory or hypothesis is hold true, i.e. the adaptive mechanism play a role in the fatigue, then the adaptive mechanism that will come into play would depend on the length of duration, because there may be more and more adaptive mechanism. And of course, there may be plasticity as well, because some of the adaptive mechanism may be totally reversible if it is there for 3 months, but it may not be so reversible if they exist there for 20 years. So there may be similarity as well as differences.
Okay, another question about fatigue, obviously. Someone asked, is it possible to have severe fatigue even if she doesn't have antibodies and a very, very little inflammation showing in her lip biopsy? So she is wondering whether she can have very severe fatigue with no inflammation in our body.
Well, first of all, I think what I would say is that you should never doubt your own experience. So if you are fatigued, you're definitely fatigued. So it is definitely possible. So I think the question, as I alluded to when I tried to explain the pathogenesis, I don't think inflammation is a prerequisite for fatigue. So in fact, it's highlighted what I mentioned earlier. Inflammation may well be important, but certainly not the only factor. And I think this is actually quite commonly observed in my own clinical practice. Many patients with very little evidence of systemic inflammation that we could detect and yet severely fatigued. And I think the frustration, in fact, is actually how do we explain to the patient, they must think, oh, so what's wrong? I mean, I think I would really encourage people not to hang too strongly on the fact that inflammation is the cause of fatigue. In fact, it doesn't mean that what I'm not saying is that inflammation cannot cause fatigue. It's just inflammation is not the only reason causing fatigue, and lack of inflammation doesn't invalidate your experience, nor it just suggests that there may be other mechanism, and we mustn't keep chasing down the line of inflammation, because that would be a blind end, a dead end that would help no one.
That's clear. Thank you. Another question about the weather, the sunny weather. Someone said that she's really better with a sunny weather. She feels more energetic if it's sunny, and even with a temperature up to 22 degrees. So she asked, is there any explanation, and if vitamin D plays a part?
Yeah, well, of course. I mean, is there an explanation? I like to hear that there is an explanation. At the moment, I don't know the explanation, but I think, again, it seems to be quite a common association people reported to me. It's particularly true for my mother. So I got that question a lot. So I'm afraid that I haven't been able to give a satisfactory response to my mother, and I can't give you a satisfactory response either. But I think there are a lot of possibility. I think it's interesting that you raise whether vitamin D play a role. We do know that vitamin D can play a role, but but you probably also heard about something called seasonal affective disorder. So as I said, our mood can also affect our fatigue level. So I wonder whether that may change. And also, I think temperature make a difference as well. We know that as when you exercise, you are advised to warm up. So actually, maybe that if the external temperature is higher, maybe it's easier to get the body to warm up to an operational temperature. I don't know, I'm just speculating, but I'm pretty sure there are explanations, but it's very interesting observation.
Speaking of activity, what do you think, Professor? What is the level of activity we need to do to help for fatigue? I guess it's really individually to decide, but what do you think about activity to help reduce fatigue?
Yeah, so I think you gave the perfect answer anyway, because I think it has to be individualized. We started with different physical capacity. I think that's why in this particular area we often try to elicit help from our physiotherapy colleague, because they probably understand a lot more about how to improve cardiovascular fitness. My own kind of general rule of thumb when I discuss with patients is often, just to make sure. I think that there are three elements. A is that don't try too hard too soon. B, making sure you allow yourself your time to recover. because actually building anything, recovery is as important in training. So don't try to say, oh, I want to push myself, so I increase my level of activity every day by 3%. But actually, even that, every few days or even every day or two, you need the recovery, because recovery is actually a very important phase to build in the training element, to allow the training element to embed it into the system. And also, I guess, listen to your own body. I think often, if you talk to a professional, they may say, okay, you follow this schedule, but if your body tell you otherwise, you just need to adapt it. You need to talk to your clinician to say, well, this is a bit too hard for me, let's adjust it, and not take it as a gospel. I know many patients are so good at following regime, and some of them don't, but also some so good. And even though their body clearly doesn't quite fit in, they will just, oh, but my physio tell me to do this, and end up actually making things worse. So there is no easy answer, but I think, so I hope, those provide some principle for it.
Yeah, anyway, activity is important for Sjögren's. So,
yeah, absolutely.
Yeah, okay. And a question about your ID fast trial. Someone asked how to become part of it.
Okay, well, thank you for your interest. At the moment, so at the moment, the feasibility study has been completed, certainly for the immune-mediated rheumatic diseases. We're only still recruiting Huntington disease patients in Germany. But we are going to run the big, clinical validating study. So at the moment, we are planned to start recruitment in the summer, or maybe even Q2 if we are particularly efficient. So look out for it, and we are working precisely. That's why we're working with Sjögren Europe, Lupus UK, BSSA to develop strategy to make sure this is well publicized. We are really interested in develop strategy to make recruitment as easy as possible. There are some on the site study visit, so there will only be a certain number of sites in the UK and in Europe to take part, but we will try to think of way to make recruitment easy, to make kind of remote recruitment, virtual recruitment as much as possible. So this is still in development. I think COVID-19 has helped us to learn quite a lot of these approaches, and we'll take those learning into our planning.
Well, great to know that many patients want to be involved in trial, so that's very, very positive. Another question about diet, Professor. We often listen and we often hear that a diet without gluten or lactose would possibly improve fatigue issues. What is your opinion about those diets?
Well, I suspect, again, this is likely to be individualized, really. I mean, I'm not a nutritionist, so I really don't know enough about, the individual component. And there are clearly some people are, gluten and lactose intolerant. I am not a gastroenterologist or a nutritionist, so I can't comment on this. But you may remember in one of my earlier slides, I mean, there are certainly certain nutritional or supplements that may potentially play a role, and antioxidation or anti-inflammatory, they may potentially play a role, but I never run those studies, and I don't feel comfortable about endorsing a particular diet. But I equally hear quite a lot of story from our own patients who feel that it's helping them. I think my overall view is that I think there's no harm trying a particular type of diet, but I think be very careful. Don't go for something that are very restrictive, because that can actually have detrimental effect. If you want to skip one or two components, try it out. It's fine. Try one or two supplements. I don't think it's any problem. But just to make sure you don't go too extreme and then just drinking water and nothing. That I don't think I suggest that.
Okay. Another question about fatigue, which is really interested. Do you think that fatigue could do any long-term damage to the body?
I don't want to become a scaremonger, but I do think that, yes, of course it will. Yeah. Because the way that the fatigue would affect so many different aspects. How many of those are direct, how many of those are indirect, I don't know. But as I mentioned earlier, in fact, we know that chronic fatigue increases overall mortality. Now, whether it's because through, if you're too fatigued, you're not able to exercise, you may affecting BMI, cardiovascular fitness, I don't know, but it's clearly is an important phenomenon to get on top of. So I don't know whether it's answered your question really.
Okay, you spoke earlier about brain fog, which is really not really studied. Someone asked, is there a clear link between fatigue and brain fog?
Yeah, I think it would depend on how you view what fatigue is. Personally, I said that, my view is that brain fog is a manifestation of fatigue. So the relationship is that it is part of the phenomenon. But if you wanting to, I don't know, that would be my view. So so the relationship is that it's all the same thing, really, I guess. That's my thought.
And finally, the most interesting question for all the patients: have you found any treatment for fatigue that have worked for some people? Not obviously for all the people, but have you some clues, some tips, some whatever?
I think I don't have a generic answer to that. I think I mentioned some of the treatment that people have used, and certainly some people reported their fatigue has improved. Now, this has not been subjected to rigorous, clinical trial to confirm its efficacy. So it depends on whether you consider that, some treatment has been found. And I wouldn't claim, this is my finding. So I think people have, certainly, there are some treatment that being used by people in Sjögren with fatigue, but also in other conditions that people find it helpful. I think, as I mentioned, I think that the key is that when we look into it is be open-minded about trying different things, and hopefully some of those strategies work. And also, again, depending on how you define that work, treatment work, I think it's also about setting expectation. I think if you say completely cure fatigue from going from fatigue to completely normal, then I say, so far, I don't think I have experienced any people experience that yet. But where some people do find that their fatigue become much more manageable, then I think there are certainly some treatment people have found it had helped them significantly.
Okay, someone said that you mentioned multiple comorbidities with Sjögren. Does that mean that the fatigue is higher when you've got a couple of diseases linked together? And how can you make the difference? By example, if you have thyroiditis or something like that, how can you make the difference between the fatigue from another comorbidity and the fatigue from the Sjögren syndrome?
So for the first question, I think yes and no. I mean, I think logically one would expect a more different condition you have, then more likely that the fatigue can be more severe. But of course, as you know, even within Sjögren, the fatigue level is not the same between individual patients. So it depends on, each individual contribution, how big, how small they are. But I think logically it makes sense. In terms of, how do you differentiate the contribution of different contributing diseases or comorbidity, then I think I would say that as a clinician, sometimes we just need to look at things in a practical level, because it's not so much about determining which one contribute more. I think as a practical level is what can be treated and what can be managed. So if one of the contribution factors is anemia, of course we can correct anemia. But if you think, the contribution, there's also Sjögren at the moment, there's no treatment for Sjögren, so I can't give you anything specific. And, if you have uncontrolled underactive thyroid, then you can want to make sure the thyroid replacement is adequate. So if you know that you have sleep disorder, for example, snoring, you can think about a way to reduce that so that you get a better sleep. So I think we should just look at each individual contributing factor and ask, can I do anything about it? And, if you can, then you deal with that and see what the outcomes are.
Okay, maybe another question or two. A couple of questions about the link between Sjögren disease and chronic fatigue syndrome or encephalite myalgic. What could be the link about those two diseases and the fatigue, the high level of fatigue of those two?
I don't know how to answer that question because I don't really, I'm not an expert in, well, in fact, I wouldn't say, in fact, I really see very few CFS patients. So it is not a condition that I have a lot of deep understanding. So it makes it very difficult to comment. But I would guess, I mean, but you know, I really don't want it to. I would guess that potential mechanism that we identified in Sjögren or other chronic diseases with fatigue may potentially be applicable to explain the fatigue component of chronic fatigue syndrome. But I think, you know, from my limited knowledge, I mean, chronic fatigue syndrome is not just about fatigue. I mean, they have a lot of symptoms as well. And I don't really understand the pathology or the disease itself. I met not that many patients with that condition to make any sensible comment, I'm afraid.
Thank you. Well, I guess it's okay, Linda, if you want to conclude. Thank you so much, Professor, but we don't have any more questions. Thank you.
My pleasure. Thank you.
Thank you, Phi. This lecture has been the launch of the Sjögren Europe campaign for World Sjögren's Day on the 23rd of July. There will be a series of posts on aspects of fatigue on the Sjögren Europe website and other social media. So please go to sjögreneurope.org or follow Sjögren Europe on Facebook, or look to the website of your own organization, particularly if it's a member of Sjögren Europe, because they will be sharing these posts. And then on the 23rd of July, which is Sjögren's Day and is the culmination of the campaign, Sjögren Europe will launch a booklet with advice on coping with your fatigue. It's written by Professor Rinne Guinan, who you might have heard speak at the first Sjögren Europe webinar back in last November. So Phi, I want to particularly thank you for an excellent start to this campaign, informing and educating us. And thank you for taking the time out of your exceptionally busy life to speak to us. And thank you also for all that you do for the Sjögren community. I know how much you do. I know Coralie has a good idea as well, because we both worked with you on one of your other projects, not the one you were talking about today. And I worked with you also on the BSSA board, and your input is phenomenal and invaluable. And I want to thank you for that. So this has given me a very good opportunity to thank you on behalf of every Sjögren patient, particularly all of us listening to you this evening, and on behalf of Sjögren Europe and the BSSA. Thank you very much. And if we could all hear a clap, you'd hear us all clapping. Thank you.
Thank you.
And that's the end of this webinar. It will be posted on the Sjögren Europe website and be accessible that way, and also probably via the BSSA website and by some of the member organizations. Thank you very much, everybody, and good evening.
Yeah, good evening. Thank you again. Take care.
Thank you, Phi. Thanks.
Thank you all.
Bye.
Bye-bye.
Bye.
Thank you very much.